Good morning, everyone. Thanks for coming. So we've run a few of these meetings now for patients, and I must say that they've been the best things that I think we've ever done at Murdoch for giving patients the information that they really need. So the idea is that I think from our experience before, that most of you guys are coming up to having joint replacement or have had a joint replacement that hasn't gone well or something like that, and want to know a bit more information about the possibilities out there, really about osteoarthritis and other degenerative hip disease that may need hip and knee replacement. So feel free to ask questions. It makes it much more interesting for me to have some questions, and often entertaining. So that's good. I was at the university yesterday, and the medical students were asking some bizarre questions. So about the same subject. So that was good. So my name's Piers Yates. I've been an orthopaedic surgeon here for 16 years or so. We're going to cover these areas today. May not reach all of it, but we'll try and cover most of this stuff. Causes of arthritis, common question for people coming to have their joint replacement. When should they consider an operation? When should they ask for referral to an orthopaedic surgeon from their GP? What operations are open to them, and what other treatments are open to them? ERAS, anyone heard of ERAS? So ERAS is a general term for early rehab after surgery. So it started in general surgery, but it's been quickly adopted across all surgical fields. So it's talking about getting people back on their feet and back into full function as quickly as possible. And we've been leading that, WA's been leading that in the world, both for general surgery and for orthopedics. So it combines the important factors in anaesthetic, in surgery, in blood management and pain management, all those things all added together, and we'll come back to that later. Because there's a lot of questions around what kind of anaesthetic and things like that you need for surgery. Talk a bit about unmet need for patients. That's always a consistent problem in the world of orthopedics. What can you really expect after a joint replacement? It's not like going back to when you were 20. And people that tell you that, and people that tell you that your hip replacement is going to last for 50 years, it's ridiculous. These are not getting you back to a 15-year-old. They are very, very good operations, but you've got to have the right expectations, otherwise you'd be disappointed. Talk about what's on the horizon, what improvements are available, and then some common controversies that we're frequently asked, both in hip and knee surgery. So my practice, we founded it 7 years ago, I think, 7 years ago, yeah. And these are our current members. Unfortunately, Boris, who's our foot and ankle surgeon, just about to retire because he finds it more interesting to be with his grandchildren now and play tennis and go fishing. So he's just about to retire, and he's fantastic. So he's going to be sorely missed, but the rest of us guys will try and make up. We have a number of sort of joint appointments where all apart from Ben Widder at public hospitals. Ben does a lot of outreach stuff at Kalgoorlie and Albany, so he does his bit as well, but we're all got major teaching hospital jobs. We've got 4 heads of department in our group at the moment. We do a lot of research. We founded the Orthopaedic Research Foundation of WA, which is the biggest output of research group in Australia at the moment. And we work at the Mountain Hospital. Our clinics at the Wexford and the Mount, and surgeries at Wexford and the Mount. And some of the surgeons work at other hospitals. We cover pretty much everything. With Boris going, unfortunately, we don't cover foot and ankle anymore, but we'll look for a new surgeon. We also cover anyone from Coburn, so the acute care service there. We cover their orthopaedic needs, both public and private. Loads of research going on. We're starting up a sports injury clinic. That's just in its infancy at present at Murdoch. That's a Murdoch incentive. And we run the trauma service both here and at Fiona Stanley, which is the busiest trauma hospital in Australia. So my own interests, hip and knee, revision trauma. I've designed a number of implants. I've designed about 4 implants at the moment that they're currently using. do quite a lot of teaching. I review for at least 12 orthopedic journals, all the big ones. And my research interests: pain management, blood management, lots on blood management, arthroplasty, implant design, rehab, and revision. Revision is kind of my, so redo, joint replacements, that's kind of the thing I like doing. It's kind of complex and interesting, and there's a lot of work to be done there. And infection, unfortunately, we've got a big interest in infection because we see all the infected joint replacements. They all come to Fiona Stanley and Murdoch from all over the state to be treated. I started my training mainly in the UK. Then I've been on fellowship in the UK, in Australia and the USA. I've been head of most hospitals. I started the joint replacement unit at Osborne Park in 2006. Founder of the private practice, founder of the Research Foundation, UWA professor since 2008. I represented Australia for orthopedic research in 2012, which involved staying in America and going to talking at all their research practices across North America and Canada, and I'm currently head of orthopedics here. Outside work, got 3 children. That's my oldest child. I like rusty cars, and that's one sort of half being built, which they occasionally help with. I've got travel up here. Yeah, one day. That's just my disclosure for so that you know that I might be lying when I talk about certain implants because I designed for that company or anything, but I don't generally. So we'll start off with hip and knee replacements. What are the causes, when to refer, when to operate, and what operation you should have. So what are the causes of osteoarthritis? So most osteoarthritis is caused by what? Where people say old age and wear and tear, but they are certainly factors. Wear and tear, yeah, probably, maybe, especially knees, maybe. But there's usually a reason. There's usually a problem that's occurred, and that may be trauma. That may be a mechanical abnormality in the joint. And as we've become more recent, we've recognised, particularly in hips, that most hips wear out because they're funny shape. It's not just wear and tear. So about 90 to 95% have an abnormality that you can see if you look for it hard enough, which is the cause of arthritis. Now, at the end of the day, that may not make a difference. It's still arthritis and they need a joint replacement. But it's just interesting that some of those cause arthritis because there's a mechanical problem. And if you can catch them early enough in some occasions, then you can actually prevent the arthritis from occurring. And that's particularly the case with femoroacetabular impingement and hip dysplasia, which are the 2 common causes of arthritis in younger people in this state. In the knees, it generally is kind of wear and tear, but it's usually identified trauma. So a meniscal tear, a ligament injury, something like that, that leads to arthritis, maybe 20, 30 years down the line. But imbalances in the mechanics of the joint also lead to arthritis. So if you've got funny shaped legs, like if you're very bowed in your legs, like the vast majority of men across Asia, you're going to wear out the inside compartment of your knee at some point. And then there's congenital and acquired causes. So congenital just means that you're born with it, and acquired means that you've messed up. So arthritis, so these are the basic causes, common ones at the top: trauma, infection, inflammatory, AVN. So AVN is avascular necrosis, that's relatively common in hips. That's where the blood supply suddenly gets cut off. Very suddenly the hip becomes painful. It's a peculiar disease to humans, basically, and leads to joint replacement usually. And it's in younger people. Osteoarthritis, what we've already talked about. So the cartilage is failing. And then there's causes, causes of direct trauma to the cartilage, a direct injury to the cartilage. So trauma is a common one. So this is a 17-year-old boy that dislocated his hip. He's got taken a big chunk out of his femoral head. That's going to be a problem. He was riding a bull, which was probably the underlying problem. But yeah, so he's taken a big chunk of cartilage off his joint. That's going to end badly, even if you repair it. So that's a bad thing to do. This lady was on a Harley Davidson and got run over by a Land Cruiser, so she's got a pelvic fracture and acetabular fracture. That's likely to end in a hip replacement, however well it is fixed. So, direct trauma to the joint is going to cause a problem to the cartilage. Infection, luckily we don't see many primary infections in the UK, but worldwide this is a common cause of arthritis. So here's a kid in Papua New Guinea with pus pouring out their joint, so that joint is dead and going to go away. Inflammatory arthritis, rheumatoid, so probably a few people in the room with inflammatory arthritis. Rheumatoid is the commonest one of those, and that causes damage, direct damage to the cartilage, which then leads to osteoarthritis. Avascular necrosis, damage to the blood supply, usually due to alcohol is the commonest cause, but there are a number of drugs that also do it, particularly chemotherapy, steroids. They cause avascular necrosis, which can quickly lead to the head dying and falling off. And then osteoarthritis. And then these are congenital causes. This is the common one. This is hip dysplasia. You can see this hip has never been in the socket. So this child was born with a hip that was never in the socket. It wasn't recognised, and he's been limping around until they're 60 and now needs a very difficult hip replacement. So hip dysplasia, we see a lot of hip dysplasia in this state, and we think it's because the ancestral origin of the people that live here. So lots of northern Italians, lots of Yugoslavians, former Yugoslavian people, they have super high incidence of avascular hip dysplasia. So that's why we see them in Perth. It's unbelievably high level of hip dysplasia in this state. And that leads to arthritis. Other less common causes of arthritis. And then impingement. Impingement is where basically the ball of your hip isn't spherical and it doesn't fit in the socket. It's usually in sports people, usually men, and you can imagine if the ball doesn't fit in the socket, it's going to do damage to it, and it leads to arthritis, often at an early age, between 30 and 40 men coming for hip replacement. This is one open here, so this is the lump being taken off. So this is a preventative. So I've caught this one early, so I can take the lump off and preserve their hip. But once they've got arthritis, you're looking at joint preserving operations like hip resurfacing. In the knee, mechanical malalignment is much more important. So as I said before, if you've got bandy-shaped legs or if you've got pointy-shaped legs, then you're going to wear out your knee at some point, depending on how active you are. So the normal mechanical axis, so if you take a line through the center of the hip, through the center of the ankle, it should pass through the middle of the knee. And you can imagine, if it doesn't, it's going to end up in this compartment or this compartment, and that's going to overload that compartment more than it was designed to do. What happens in that situation? It's going to wear out at some point, usually starting off with a meniscal tear. So the compartment gets overloaded, there's meniscus tears, and that's the beginning of the end for that compartment of the knee. So here's the funny shaped legs I'm talking about. So these are called valgus knees, these are called varus knees, and these are really nice shoes. So here's an example. This is the mechanical axis in the normal knee. This is the mechanical axis in this knee. This is a valgus knee. And you can see that because the mechanical axis is over here, this is overloaded and they end up with arthritis. What happens early on when you overload your knee or you get a bit of trauma, you can have a meniscal tear. You can have a chondral separation or osteochondritis. They're all damage to the cartilage, which can lead to arthritis. So there's a picture of a focal cartilage damage in the weight-bearing part of the medial femur inside a knee. So in arthroscopy, here's the meniscus here and here's the tibia. So that's not a good thing to walk on. Menisci are very important. This is a very important fact for as you get older, your knees become less resilient to injury. And if you start taking away the protective tissues, like the meniscus and the ligaments, that knee is going to rapidly deteriorate. So taking out the meniscus in a 60-year-old is a much more dangerous operation than taking out a meniscus in a 20-year-old, because their cartilage doesn't like it. So if you've got a little bit of arthritis and you've got a meniscal tear, think very carefully about having that meniscus out, because it's an easy operation for the surgeon to do that pays them a lot of money, but it may not be the best thing for you and it might lead to joint replacement very quickly. When to refer for arthritic knees? Well, you need a diagnosis. So that's usually reasonably easy in orthopedics, but sometimes not, and particularly around the hip. So a lot of patients will come with back pain referred to the hip, hernias, vascular problems referred to the hip. And in the knee, what's the biggest cause of pain in the knee that's not coming from the knee? No. Hip, absolutely. See, every clinic will see a patient coming in, so they've been referred by their GP for a knee replacement, and they walk out with a hip replacement. Very, very common, particularly women. So women frequently get that. Older women often have that diagnosis. And it can lead to bad outcomes where the surgeon doesn't examine the patient properly and they end up with a knee replacement. It doesn't make them any better. I've seen it lots of times. So, and the other time for a GP to refer is that exact situation where they're not sure of the diagnosis. So they know there's something really wrong and it's probably orthopedic. They can't figure it out. Send it to us and we'll figure it out. What happens if you get delayed? This is a common question. So particularly in public where waiting lists might be quite long. Is there any problem leaving it longer? So you've got an arthritic knee and a lot of people put it off because they've heard that you can only have 2 in your lifetime, or what else have I heard? They only last 10 years. That's a frequent one. That's all rubbish. So they put it off for whatever reason, or they're just worried about having a big operation. So it surprisingly doesn't make a lot of difference. Obviously, the patient will suffer. They'll be in pain. They'll be limited in what they can do. But does it change the outcome? Surprisingly little evidence that it does. The difference it does sometimes is that it stops you having conservative treatment. So there's a few conservative operations that we can do in arthritis, like a partial knee replacement, or a realignment procedure in younger people, or a hip resurfacing rather than a hip replacement, or occasionally hip impingement surgery or hip dysplasia or osteotomy that we can do if we catch them early. And we can't do them if we get them late. But surprisingly rarely does it change the outcome if you wait for your joint replacement. Diagnosis is usually pretty obvious. In the hip, groin pain's your cardinal feature, but not always. So most people have groin pain, worse on activity, worse going up slopes and stairs. When it gets really bad, they feel it at night. It gets better with anti-inflammatories generally. Sometimes people feel it in their knee, sometimes feel it in their shin, particularly older women. Stiffness is the second thing. So people kind of don't notice that until it gets really bad. Question to ask them, can you put your shoes and socks on? If you can't put your shoes and socks on, then it's probably pretty stiff. Occasionally get catching symptoms, particularly early on when the labrum tears. An investigation, what's the most important investigation for hip arthritis? What's the one we want to see before people come to clinic? MRI? Ultrasound? No, just a plain X-ray. We can diagnose and plan nearly everyone from just a good plain X-ray at a health provider, at a radiology provider that we can actually see, which would be good. So we like the big ones because then we can easily access the imaging. We don't want the reports, we want the actual imaging. So we like SKG and PRC because of that. And they're actually cheap. So that's what we want. We want the X-rays, and we do most of our planning off that as well. We might do further investigations, but leave that up to us. We quite commonly do diagnostic injections into the hip joint to make sure it's coming from the hip joint if we're worried that it's coming from the back or somewhere like that. We'll do MRI scans in younger people where we're considering a non-joint replacement procedure. That's really the indication for MRI. Once you've got arthritis, we don't really need an MRI. And CTs we use for planning, which we come back to. So it's nothing to do with diagnosis, it's to do with planning the operation. So things to watch out for with hip arthritis. We've already heard this, back pain. So you can have back pain and hip arthritis together if you're lucky. Or you can have back pain that causes hip pain. Or you can have hip pain that causes back pain. Can you have that? That's really unusual. So rarely does hip pain cause back pain. And then there's the nasty things we always have to look out, like malignancy. Always have to have in the back of our mind. When to have a joint replacement? This is the million-dollar question. This is what you guys are probably thinking today. When do you have a joint replacement? It's an individual question. So it's when it's ready for you, and that is when it limits things that you reasonably should be able to do. And that might differ between different people. So some people live for golf. Some people's main exercise is walking. That's one of the common ones. If they can't walk, that's their social life over. They can't exercise, it's terrible. You know, what else is there to do? So that unable to have short distance, even significant distances of walking is a big one. Night pain's a big one. If you can't sleep, that's a really good indication for a joint replacement. That usually comes late. And painkillers, if you're using a lot of painkillers, especially if you're onto opiates, that's a pretty good indication for a joint replacement. Risks, people get this completely wrong, risks. So I was asking the medical students yesterday, what do you think your risk is of infection, DVT, blah, blah, blah. They got nowhere near. So your risk of an infected joint replacement is 1%. That's bad, but that's a pretty low rate considering it. Treatable DVT. So DVTs are really common. So about 40% of people will have a DVT after a hip replacement if they look for it, but only 1%, 1 in 100, will need treatment. 1 in 1,000 of those go up into the lungs, that's a pulmonary embolus, and 1 in 3 of those will kill you. So 1 in 3,000. Leg length inequality in hip replacement. Patients don't like having changes in their leg length that they're not expecting. They don't, they hate it, especially women, especially short women, because if you're short, you notice a discrepancy more. And the worst group are the ones that start long. So if you start long or neutral and you're made longer, you really notice it and you hate it. It's the second commonest cause of litigation in Australia. And how long do they last? Everyone gets this one wrong. So 80% of hip replacements, 80 to 90% of hip replacements will last more than 20 years. So that's pretty good. So if you're over 60, you are likely to die with your hip replacement. And that's not because it's wearing out, that's because they last really well. So they are good.
Excuse me, I have one 33 years old.
Exactly.
In Africa.
Yes. Is it a Chanley? Is it a Chanley? Chanley hip? Chanley hip? It is? Yeah, so I've seen them over 60 years old. A few when I was working in Southampton. We were seeing really the original ones, the ones done in Manchester. What surgery? That's for us to decide. We will tell you what the options are. And generally in your age group, I can't see too many young people here. So generally in your age group, we're talking about hip replacement. But we'll always consider the other ones depending on the individual. And that depends on your activity and things. So hip resurfacing we'll come back to. And then another common question is uncemented or cemented. That's a big one. And that is defined by your bone quality. So if you're osteoporotic and you've got weak bones and maybe you've had a fracture or something like that, and your canal morphology suggests that you're osteoporotic, then cement is going to do really well for you. That's like we used to do for the original hip replacements. They do extremely well. And if your bone is really good, then we use uncemented prostheses. Arthrodesis, we don't do any. Osteotomy, we do in people that we got. So here's an arthrodesis. Don't see these very often. So this hip has been joined to the pelvis. Used to do that before we had hip replacements. Really horrible operation. Patients hate it. But there's still a few people around with them, and I take one down about once a year. So I'll take one down and put a hip replacement in. Osteotomy for the young patient. So again, these are people with conditions that we can treat without a joint replacement. So here's a 35-year-old bilateral dysplasia. So you can see how shallow her cups are. So she's got really bad pain in both hips, debilitating, just like having an arthritic hip, but without arthritis. And she gets bilateral osteotomy. So break her pelvis both sides, swing it round on top, and now she's got deep sockets. And she's likely to keep those hips for another 20, maybe 30 years before she requires a hip replacement. So that puts her into 55, 65, normal age for a hip replacement. Job done, very good. Young active males, 44-year-old male, this is the manager of the Cottesloe Rugby Club. So bilateral hip resurfacing, sort of kind of fancy operation, only a few surgeons do it. Our practice does 95% of them in Perth. It enables you to do anything. So you can run on these, you can do marathons on these. Several of the SAS soldiers that are based here have got these now, and they're back in doing whatever they do, back fighting and things. So great hip replacement. You have to be young, you have to have good bone, and you have to have high activity. So we're talking sort of under 65, already trying to do jogging, running, sport, that kind of thing. So it's not for your average person. Younger females, they get conventional hip replacements, basically. We might use slightly different bearings, but normal hip replacements. Onto the knees. So any other questions about how you wear out your knees, wear out your hips, and kind of what the options are for hip replacement in a vague sort of way? Yeah.
My biggest problem is they keep coming loose.
The implants?
Then the one that goes down in the middle of the bone.
Yeah.
I've had that twice now.
Yeah. Yeah.
Causes it.
Commonest causes infection, and often unrecognised infection. So very sort of indolent bugs that take a while to, or take special tests to actually identify. So whenever we see implants that are not behaving like they should, number one, infection. And that's not the kind of infection that makes you sick. It's the kind of infection that happens exactly what you're talking about. Your implants become loose over a period of years, and they fail.
Yeah.
So infections to be excluded. And then there's occasionally some really obvious mechanical reasons. You know, wrong choice of fixation, wrong choice of implant. And then there's rare biological causes that your bone just doesn't like healing to anything.
What about job, or I'm a truck driver?
Yeah. Yeah, so on it's the stem size that's the problem, the bit that goes down inside the femur.
Yeah, that's coming loose.
Yeah, so that would still be very unusual. So people that are high activity or in heavy jobs, they don't usually damage their stems, they damage the bearings.
That's the ball.
Yeah.
It's happening for the second time now. So,
Yeah. Infection would be number one.
so how do I find out if it's
You need to see a surgeon that does lots of revisions. No, I'm serious. It's one of the problems we have in orthopedics is you have vast majority of people can do a really good job with a primary hip or knee. That's fine. But when something goes wrong, then you need to find someone that does a lot of those, because it's really, and it's often the diagnosis which is the big problem. You know, once you've got a diagnosis, you can instigate a proper treatment, but until you've got a diagnosis, you're just going to repeat the same mistake. So you find a revision surgeon. There's a few around town that are big volume revision surgeons, but you want to find someone that does it every day, not someone that does primaries every day.
Would I find one at Murdoch?
Yes. So I do lots of revision. It's my interest. I'm not saying come to me, but and I can give you names of several others that are really good. So I'm not trying to sell myself.
With kids, I think you mentioned that potentially if there's a child, teenager or young adult
Yeah.
has an abnormal hip,
Yeah.
it could lead to
Yeah.
something in the future.
Yeah.
Is it worthwhile if you suspect that, or can a child, say a young teenager or so, have an X-ray and be diagnosed that they might have something?
Absolutely.
Is that common, or
Yeah.
is that, so if the parent suspects that a child may have a problem, they
Yeah.
can come to someone.
Yeah, so and again, that's a more specialised thing. So in our practice, Gareth Prosser, who's my most senior colleague, we started the practice together, that's his specialty. So he does hips and knees and similar to me, but one of the things he does the conservative hip surgery, so in teenagers. So he's the person to see if you've got a paediatric or young adult hip problem.
Okay, but you could diagnose a young adult that may not have an issue at the moment, but it potentially could have one in midlife or something like that.
Yeah, so that's one of the problems with medicine in general. It's reactive. So people only come to us when they've got a problem. So there's very few screening programs in orthopedics. So hip dysplasia is screened at birth with the clicky hip things on all the babies, but other than that, there's no real screening. So you'd have to have symptoms. Most people have symptoms before they turn up to us, or a really strong family history. So I've seen a few people that have come with worn out hips at a young age, and they've said, my daughter's got clicky hips. And then I've seen them, but they're completely asymptomatic really. And then we've picked them up from there. But without symptoms, first of all, they're not going to present, and secondary, we're not going to offer them a big operation without symptoms. So people are usually symptomatic. But yeah, there's a small group that may benefit from asymptomatic assessment of their hips.
If you have an existing hip replacement, mine's
Yes.
just starting to hurt a little bit.
You said it was really good.
No, it didn't. I can walk, but sitting and lying.
Yeah. Has it been followed up?
Well, no, that's what my question is. Can I just walk until I'm not walking?
No, definitely not. So, and that's another issue in orthopedics, is that people are happy to slam in a couple of hundred hip replacements a year and then discharge everyone. But what happens to them in 10 years' time? So my follow-up protocol is I see everyone at 1 year, and that's more just to make sure I've done a good job and kind of feedback to me. But also at that point, if everything's good, then that's going to be good for probably 20 years. And then it also allows me to pick up the ones that I think they might have a problem early, so I'll see them earlier. But if that's routine, it'd be 1 year. And for hips, then I see them at 10 years. I don't see them any time between. So 10 years, and then every 5 years after that with an X-ray and a clinical score. That's it. Because, especially as hips start to wear out, so your hip has got terrible plastic in it, and it produces bone debris that can lead to a big hole in your pelvis that may be unreconstructable, and it'll be asymptomatic till it fails. So it'll fail suddenly, and then it may be unreconstructable. So you need to have an X-ray 10 years, 15 years, 20 years, 25 years, and to have someone see it that knows what it means. Because if you can see them wearing out, then you can do a good revision, a conservative revision that will give you another 15, 20 years. And if you wait too long, it becomes very difficult. So it's a simple thing to do. Yeah. Yes.
So after knee and hip replacement, how long it takes to recover, and what sort of exercise do you choose?
Yep, we'll come to that later. So, so knees, just going back to knees again, this is what people present with. It's pain again. All these things are painful, aren't they? It's orthopedics, it's painful. It's painful and functional problems. Pain in the knee is usually in the area where the arthritis is. So on this one, it will be on the outside. Most people get pain on the inside because that's where they wear it. It's worse when they use it. Whereas hips, they're better, they're stiff in the morning, they get better during the day, and then they get all their pain when they stop walking around. Often, not always. Kneeling is often trouble. They get night pain relatively early. They get a lot of swelling. And Baker's cyst, everyone knows what Baker's cyst is. So we get referred patients all the time. They've had an ultrasound, they've got Baker's cyst. And the Baker's cyst is a function of the fluid production within the knee. So the knee is producing a load of fluid, and the fluid pops out the back. That's called a Baker. That's all a Baker's cyst is. So there's no point treating the Baker's cyst. You've got to treat the cause of the Baker's cyst, which is usually arthritis. But it could be any cause of inflammation in the knee, like inflammatory, like rheumatoid, like bursitis, or like infection, really, things like that. So, but the point is, you've got to treat the cause, not the Baker's cyst. That'll always end badly. Giving way and catching. So if your knee's giving way and catching, that usually suggests that you've got a meniscal tear, which in your age group is going to be a degenerative meniscal tear, which again may not be amenable to arthroscopy and may be amenable to joint replacement or conservative treatment. And then instability. Some people come with instability and stiffness. Investigations. What investigations do we want? An X-ray, yay. So a weight-bearing X-ray, which I think nearly all radiology providers and GPs understand now. So we want you standing up when you have the forward X-ray, because that shows us a true amount of cartilage loss in the knee. That's the most important X-ray that we have. And there's two other views, one side view and one shooting behind the kneecap, just to see that. And always consider the hip. Just Diagnosis. Now here it's slightly different to the hips. We have the X-rays. We can diagnose most of them with that, but often it's not arthritis, and it might be a meniscal tear or something that we can't see on an X-ray. So we frequently will do MRI scans in poorly knees, and there lies a problem because GPs can't order them. So if a GP orders an MRI scan for you, it will cost you $300 or $400. Where if I order you an MRI scan, it costs you nothing. So they, instead of, and what they do sometimes, they compensate for that, is that they'll order you a CT arthrogram, which costs you nothing, but it's not a great test.
Is there some new test that's a whole body thing?
So that's EOS.
Yeah.
So that's to do with alignment and planning. So that's not to do with diagnosis. Hello? At the back?
Yeah, does arthroscope defer knee replacement or not?
Only if it's done for the right reasons. So most arthroscopies that are done for degenerative knees are pointless exercises and often speed up the process of arthritis. And the reason they do that is because they take out what's left of the cushioning soft tissue in the knee. So if you've got established arthritis, unless you've got mechanical symptoms, which means the meniscus is catching and jamming your knee so you can't get around, you are unlikely to improve with an arthroscopy in the older age group. That's different if your cartilage is normal. So if you've got normal cartilage and you're 25, you're likely to do really well with an arthroscopy. But if you're 65 and have got arthritis and have a meniscal resection, that ends badly, and it usually actually speeds up the process. It's a traditional operation orthopedic surgeons do because it's easy and it's quick, and it's one of the worst problems about patient expectation that I see, because they'll walk into a surgeon's office, they'll say, you've got a meniscal tear next Tuesday, without any other discussion, just because you've got an MRI scan. You have your meniscus out, you think, oh, it'll be great, and you're no better or worse. And then you lose all faith in that surgeon. I don't know why people do that. You've got to be really clear with that group and say, you know, the chances of this making you better, if you are going to do it, the chances of this making you better are low, and you're likely to end up with a knee replacement.
So what's the alternative at that stage?
So usually conservative. So often that's the time we'd use injections just to settle things down, because it's usually a temporary problem. So most meniscal tears in a degenerative knee will improve by 6 weeks with appropriate treatment. But that's active treatment. That's not just hoping it goes away. So it's appropriate physiotherapy, appropriate strengthening of your quadriceps, weight loss long term, injections and the right medication, and maybe a walking stick to offload it temporarily, things like that. So a conservative approach.
If someone has a bad knee,
Yeah.
and maybe the leg is severely bowed,
Yeah.
could that likely cause issues in the ankle and the hip?
Yeah, absolutely. Yeah. So bad knees cause problems with the hip and the back. Everything causes every imbalance will cause problems with the hips and the back.
With your X-ray,
Yeah.
so the initial X-ray,
Uh-huh.
do you get the X-ray of the whole leg, hip to ankle, or is it just the knee?
So if we're considering, so we'll examine them. That's, some surgeons will examine you anyway, and particularly looking for the back and the hip. If we're concerned about those, we would do further imaging, particularly the hip frequently. And then if we're doing planning, so we're planning an operation, we will get full length, top to bottom.
I guess to get to see someone like yourself, I understand the GP has to provide
Yeah.
a referral.
Yeah.
Is it worthwhile when someone goes to that initial GP for a referral,
Yeah.
they ask the GP to get
No.
the X-ray as well?
Only the normal X-ray series.
So the normal X-ray
Yeah.
series,
Yeah.
and they will know what that is.
Yeah.
I'm just wondering, does that help you in the initial meeting?
That's all we need initially. If we need, like in our practice, if we need added simple imaging like an X-ray, we've got SKG directly below us. So we can send you down during the consult for any further imaging, if it's just an X-ray or something like that.
So if we were going to go to the GP and say,
Just get normal knee series.
normal knee series,
Yeah, yes, yeah. And that would be more than most people. So people turn up to the clinic with an MRI scan or an ultrasound, and we go, right, I'll go and have an X-ray.
But I guess that's advisable if someone wants to come and see someone like yourself.
Yeah.
Instead of just presenting.
So what happens in our practice is you ring in for an appointment. The girls will ask you what imaging you've had, and they will direct you to have the right imaging before you come. If you don't even need to see a GP for that, because they will send out a appropriate form to you before you come to the appointment to have the appropriate X-ray. So when you come to the clinic, you'll at least have that AP pelvis, or you'll have that weight-bearing knee series before you turn up. That's what happens at our practice. So that immediately saves you a consult, and it immediately saves you a day of doing something else and having to go, well, you know, go and have this X-ray and come back in 2 weeks. Which is, I think, is rubbish.
I've been a patient at Royal Perth Hospital outpatient since 6 years.
Was that just one appointment, or?
Regular. Can I get the information from all of that sent to, say?
Yeah, we frequently retrieve private, especially in private practice. Private practice is very isolated in terms of information, but they are duty bound to share information if you ask for it, so that they can't deny us information. So if someone wants information from our practice, that we just send it as long as we've got the patient's permission. Yeah, so it's not a problem. Even the public hospitals, the public hospitals can take a little bit of time, but they're actually getting a little bit easier. Most of us work at public hospitals as well, so the next day that we're at the public hospital, we can just pull it off the system ourselves often. So no, it's not a problem at all. And luckily in orthopaedics, we don't actually need to know that much, to be honest. Most people, some people are a bit complicated. Right, so further investigations. I keep coming back to the hip. It's a bugbear of mine. You know, if you've got knee pain, it might be your hip. What kind of surgery? We've talked about these realignment surgeries, unicompartmentals, total knee replacement. Don't do arthrodesis anymore. Arthroscopy, we've talked about this again. No good for degenerative pain. Painful meniscus in a degenerative knee does not do well with arthroscopy. Tibial osteotomy. This is for the younger active patient with unicompartmental disease. So in this operation, we are changing that mechanical axis of the leg to offload the worn out bit and load the good bit. So you must have a good bit. That's number one. You must be in the right sort of age group. There's no point doing this operation in a 75-year-old because they're going to do brilliantly with a joint replacement. But it is worth doing this in a 35-year-old FIFO worker. That's the age group that we're really aiming this at. So young people, usually men, because they tend to wear out this part of their knee. They have to have basically the rest of their knee has to be pretty good. It's a great operation, but it takes a while to recover, but great operation in a select group of patients. Indications for joint replacement. I remember being taught about joint replacement. What are the first 3 indications of joint replacement? Pain, pain, and pain. But as with the hips, interferes with lifestyle, night pain, painkillers, same as before. Risks of knee replacement. These are similar to hip replacement, slightly more infection with knee replacements, just because it's very superficial, the skin can be a bit dodgy. So slightly more infection with knee replacements, about 1.5 to 2% really. But this is the big difference. So traditionally, 20% of people after knee replacement are not entirely happy with their knee replacement. That doesn't mean they don't appreciate that they've had it. They're just not fully satisfied. And that's only about 5% of people that have hip replacement. So this is the group that we've been working on recently to try and narrow down that gap. And what we found, what's the commonest reason for dissatisfaction after a knee replacement?
Rehab pain.
Rehabilitation.
What's the cause? No.
Bad operation.
No. That's what people assume. It's poor expectation, inappropriate expectation. So people are told they'll have no pain, they will have full range of motion and it will last forever, you know, that kind of thing. It's not true. Especially knee replacements. They do not feel like normal knees. It's rare someone will come into the clinic and say, I've forgotten I've got a knee replacement. It's common that people will do that with a hip.
Having said that, do those 20% before the operation find it difficult to walk from here down the passage,
They might well do, yeah.
but after it,
A lot of that group, most of them will still be much better off than preoperatively. But they won't be. It won't hit their expectation that they were expecting, and therefore they're dissatisfied. That's what expectation is.
But a lot better than what they had.
Yeah, usually, not always, but yeah, usually. We'll come back to that. So, so this is what to do. Get the right expectations. Tell them what is really going to happen. How many people are going to be able to kneel comfortably after a knee replacement? So this is a good news story. So it used to be 5%, and with the new knee replacements that we're using now, the new generation, 55%. So a massive increase in comfortable kneeling. Huge change. And that's the last 5 years. Abuse, so people doing things on knee replacements that they really shouldn't, and that is like running on them basically, and then going, oh, why is it painful? Think about your other joints. So you might sort out your knee, but your hip might be worn out or your back might be worn out, and they're still going to be bother. So just because the knee's done, that's it. Bilateral, that's a question we're often asked. So people frequently, both their knees are wearing out pretty much equally, and they say, can I have bilateral knee replacements? I used to do lots of bilateral knee replacements. The main medical risk for not doing it is heart disease. So if you've got significant heart disease, don't have bilateral hips, that's the risk factor. But other than that, it's a pretty safe thing to do medically. The problem is it's painful and it takes a lot to rehab. It takes a lot to rehab a normal knee. So think very carefully about having bilateral knees. I would not have bilateral knees myself. I would have them staged. And I think people who have them staged do much better than having them bilaterals. Now, people got different opinions about that. Some people want it all overdone in one go. Some surgeons like doing bilaterals, some surgeons don't. It's a discussion, definitely. There's no right or wrong, but knee replacements are hard work afterwards for you guys. Think carefully about having them both done.
just as an extension to that, do you ever do a knee and hip on the same side?
Never.
at the same time?
I know a surgeon, a friend of mine did that once. He said, don't do that.
In terms
And you
of,
always do the hip first.
in terms of pain, is there more pain because there's two, or
Yeah, well,
it increases the pain, or what?
It does, but probably the biggest factor is that it goes on for longer. So the problem with knee replacement rehab that the patients find is the length of time it takes to rehab them. It's not that they're super painful, because we're much better at pain management, but it drags on for weeks. So you will have significant pain in a knee replacement at 4 weeks, particularly at night. And patients hate that constant pain. And if you have both done, it's going to be even longer.
So if you stage them,
Yeah.
how far apart are we talking?
So 2 weeks is enough, but patients generally don't like that. What the common scenario is, say, oh, you need both your knee replacements. Say, can I have them both done at the same time? Say, oh, I don't think that's a good idea. Have them staged. Say, all right, well, I'll book you in for one. And say, can I have my next one done in a month or 6 weeks? And say, okay, I'll reserve you a date. They come back at their post-operative appointment and say, oh, my old one's better. And they're better because they're on painkillers for the first one. I've usually injected the second one during the operation to give them temporary pain relief, and they're doing all their rehab and things, which is actually helping the other one as well. So then they go, oh, I'll put it off, and it usually ends up 6 months. That's what usually happens. But 3 to 6 months, I'd say. Uni knees. Everyone heard of uni knees? So these are good when one part is worn out. They are particularly good for middle-aged females, and they do very well. Fast recovery. It feels like a normal knee. These are the ones that do feel like normal knees because you're keeping all the ligaments, you're keeping everything but the worn out compartment. So the rest of the knee's still there. The big downturn of this is that if you look at long-term results, they are less reliable. So they're more likely to fail at 10 years. But if you look at 20 years, they're the same as total knee replacement. So there's a bit of a blip at 10, and they come back up again at 10 years, they're about the same. So they are a good operation if you are appropriate, and that's where the thing is. So the surgeon's got to make sure that you're appropriate for that operation. So they've got to make sure the rest of your knee's good, basically. Good operation. So what do I do? Total knee replacement for most people, including, so occasionally you'll get people coming in that have just got worn out kneecaps. So the back of their kneecap's terrible. They've got big problems on stairs and slopes. It's ruining their lives. They can't do anything. But the main part of their knee is normal. Now, there has been various operations for that over the years. None of them have worked very well. The reliable operation is to replace the knee, even though you're chucking away 2/3 of a normal knee. You want an operation that works. How long do they last? We talked about that before. 80% will last more than 20 years. 5% fail at 10 years. That's just a lady walking up the ward 22 hours after a knee replacement. You can't tell which side it is. So that's how some people are occasionally. So just a few cases. Smashed pelvis, young person, knees smashed as well. Fix it, pretty complicated operations, one of the hardest pelvis I've ever done, very difficult. Wears out, gets to hip resurfacing, and it's off and running and doing sport, and great. Right, this one's a good one. 50-year-old female with knee pain. X-ray looks pretty normal. Other surgeon puts in knee replacement, patients know better. It's because her hip's arthritic. So she was sent for a revision of her knee replacement. There's never been anything wrong with her knee. 47-year-old boilermaker, heavy job, just got disease. This is an MRI scan, and the disease is just in this compartment here. High activity, debilitating pain, osteotomy. So realignment osteotomy, break the tibia, fix it, straighten everything out, partial weight bearing for 6 weeks, and then off they go. So they've got a normal knee again that will last another 10, 15 years in a heavy job. I'll go straight on to the anaesthetic side of things. ERAS we talked about before, so that's just looking at all the things that get people back on their feet, all those little differences that make a difference to how fast you recover, adding them all together, making a significant improvement. This is where we started when I started as a consultant. This is the kind of incision we'd do for a hip replacement. People, when I started at this hospital, which was 2010, people were in the hospital to have their clips out still. They hadn't gone home. They were in hospital at day 12. It was ridiculous. Think how much does a hospital bed cost a night? 200? A bit more than that? 700? Any raise?
2,200?
Yeah, $1,500 a night. So health funds, which is us at the end of the day, don't like paying $1,500 a night when you could be at home. And it's not that you could be at home, it's like you should be at home. That's the better place for you. So management was poor. So I was just remarking to one of our ward nurses this week. I went up to the ward, I'd done 10 joint replacements that morning, and they were all on the ward. You couldn't tell that they had an operation. They're all having lunch. They all looked fine. When I was started, those patients would be screaming in agony on ICU, having a blood transfusion. It's just everything's changed. Incisions were big, blood loss. 30% of knee replacements had a blood transfusion in 2003 in WA. That was normal. What's the percentage now? 0. So 2011, Fremantle Hospital, which I was head of department of at the time, had the lowest rate of transfusion after joint replacement in the world. We led the world in transfusion. Infection hasn't changed. Infection rates are about 1%. They haven't changed. But the cost has. So the cost of having a joint replacement is changed a lot. So the features of ERAS, this recovery program, is multifocal. So it's a team approach. Everyone has to be involved. The patient has to be involved. The nurses, the admission people, the surgeon, the radiographer. Everyone that sees that patient has to tell them the same thing. Otherwise, they'll get a mixed message. You do limited soft tissue injury. So we do small incisions where we can. But what's important is what we do inside. So it's not important how long the skin incision is. That depends how fat you are. It's what we do on the inside. It's how many muscles you damage and how many ligaments you cut. That's what makes the difference to recovery. And that's what happens on the inside. And that's where we've been focusing. We've stopped using tourniquets. I haven't used a tourniquet on a knee for years. That really helps with post-operative pain because tourniquets hurt. Everyone had a tourniquet on, like a blood pressure cuff. You know, you only have it on for 30 seconds and that hurts. Imagine having it on for an hour. Bloody hurts. Cold therapy, we're efficient in surgery now. Manage blood properly. So tranexamic acid has halved the blood rate. That's just a tablet. It costs $7. We give good anesthesia. We get people up and about. So my patients will walk 1 hour after their operation. They'll be walking with crutches independently on day 1, and they'll go home on day 2 after a hip replacement, day 3 after a knee replacement. Clear, consistent message from everyone, that's really important. And lots of different weird painkillers, all acting in different ways to cover pain. Same lady again, bilateral hips, same day of surgery. So this is what to expect. You turn up at your appointment. I tell you what's going to happen. I tell you how long you're going to be in hospital. I tell you you're going to get up an hour after the operation. I tell you what anaesthetic you're going to have. So that's before you're seeing anyone else. I give you some literature. I lead you to a website that will give you more information. You're involved. You're part of the solution. Patients like that. It's good. Preoperative workup, just the normal things for anaesthetists. I don't send my patients to my anaesthetist, but I talk to them a lot. So about 1% of my patients will see an anaesthetist preoperatively. The rest, I sort you out before you go to surgery. This is the anaesthetic. This is a spinal anaesthetic. This is what it looks like. So you have a little drape over here, clean up the back, shove a needle in. It takes about 7 minutes to do usually. Some people are difficult, but it's rare that we can't do that. It's a very good anaesthetic, and it reduces your bleeding, reduces your pain requirements, gets you up early. It is very good. This is important. This talk was written by my anaesthetist, but this is important. So you can give tons of painkiller and you will have no pain whatsoever, but you won't be able to move and you'll be comatose. That's no good. So what you want to find is the balance. You want to find where you've got good function because you've got good pain relief, not complete pain relief, and you want to be able to use your nerves. You don't want to be paralyzed like we used to with epidurals, but you're in good. You've got good pain management. So you're up and about. You've got great function. That's where we want to hit. Not too much, not too little. Prehydration. So my patients drink before they go to drink water. That is. Before they go down to theatre. So you can be drinking water before until you go down to theatre. So until 10 minutes before the operation. I think that's really good. And we encourage people to have sugar in that. So like Gatorade or sports drinks, that really helps. And that stops people fainting and afterwards and things like that, and stops people getting narky as well. Keep all the medications are pretty much kept normal. There are exceptions to that, like diabetic medication sometimes, particularly anticoagulants, which we have to be very careful with. We'll tell you about that. But most medication we keep the same, and tranexamic acid halves your bleeding rate. Come into the theatre, spinal in. That's probably the last thing you remember is sitting on the edge of the bed. Then you forget everything else, and the next thing you wake up in recovery and you can move your legs already and straight back to the ward because your pain relief's good, and stand up when you get back there. You have a urinary catheter because when you have a spinal anaesthetic, you lose control over your bladder, so you go into retention, particularly the men. So everyone has a catheter that comes out first thing in the morning as soon as you start walking around properly, and that's it. So that's Alex Swan, who's my anaesthetist. You probably see him on the news quite a lot because he's always like pulling people out of Wuhan and stuff like that. We developed this new pain system over a long time, over 10 years, and they're very good at it. So my turnover between patients in theatre in terms of anaesthetics is 7 minutes. It's amazing. He's very good. Spinal anaesthetic, lots of reasons for it. Super safe, reduces DVT, reduces blood loss, low risk, do it in nearly everyone. It paralyzes you for a short period of time, so for the operation, and it gives you good pain relief for a long period of time.
My girlfriend had that. She said she could hear saws going and things. She could hear everything.
That's if you have, if you're fully awake, if you have a spinal anaesthetic. Fully awake. It doesn't do anything for your brain. So what we do, don't panic. So that gives you your complete pain relief and paralysis, and then we sedate you on top of that, but we're not giving you a general anaesthetic, so you are not aware of anything, and that depends on your level of sedation. So some people with, say, really bad lungs we might actually keep them awake deliberately because that keeps them alive. But the vast majority of people, they're fully unaware of the operation and they just wake up in recovery. But some people we deliberately keep awake. They're very rare actually.
Use Spinal for both knee and hip?
Yeah, so that's our number one anaesthetic. For knees we do a lot more on top of that. For hips we don't need to do that much more. Very good. This is the other thing. So this is the difference with the knee. So we developed adductor canal block. So your femoral nerve comes from here, it supplies most of this area here. Used to be you block your femoral nerve, but that knocks out your quadriceps so you can't move. So that was the old treatment, used to be like 20 years ago. So, but if we figured out that if you inject down here, then you knock out the sensory branches without knocking out the motor branches. So you get all the pain relief without paralysis. So, and it lasts for about 36 hours. So this has been the revolution in knee replacement anesthesia. We do a spinal, we do an adductor canal block, which is quite fancy, but easy if you're doing it routinely. And then we put local anaesthetic in the knee as well, which gives you fantastic pain relief for 24, 36 hours. Have you got a piece, what have you got in there?
Just a handing, but that's as numb as it was done yesterday.
Yeah, exactly. So that's regional anaesthetic, it's a block, just different nerve. Yeah. Good. And then in terms of surgery, we do it quickly and efficiently. We have minimal blood loss. We do minimal invasive. You know, most people do minimal invasive surgery now. Put loads of local anaesthetic in, like really large volume. And you can be awake if you want. But if you are awake, you have to tell jokes. That is the condition. Post-op, you can eat in recovery. So you can have an icy pole and you can even choose the colour. I wouldn't recommend the pineapple ones. Yeah. So have your icy pole in recovery. Patients love it. So none of this dry mouth, unable to eat for another 4 hours. It's really nice. You've got no pain. Rarely do we use drains. There's not many tubes in other than catheter. And off you go. So no tubes hanging out, no epidurals. You're switched to tablet anaesthesia and off you go. Can't share the video. Can't share those videos. One of the worries, the big worry when we introduced this was that patients will go home and then come back. The rates of redischarge have dropped, particularly in the elderly, surprisingly. So even in the people that break their hips, less of them are coming back after we instigated this because their pain management is better. So that was completely the opposite to what the critics thought it was going to be. And we've gone from 12 days to 2 days. And they're better. It's great.
You're using Mako, aren't you?
No way.
You're
No.
not using Mako.
No. Mako does not reduce length of stay. There's no study showing that. It certainly costs a huge amount of money and uses up all our theatre resources. I shouldn't say that.
Sorry, so when do patients go home? After
Day 2 hip, day 3 knee, on average. It'd be rare to be more than that, sometimes less than that.
When you say physio twice a day,
Yeah.
that's just when you're in the hospital?
Yes. Yeah, and then usually people will just sort of manage their swelling and do the exercises they were taught for the first 2 weeks, and then start their outpatient physio week 3 and week 4, including hydrotherapy.
You see errors peculiar to this, your group and this hospital?
No, it's spread. I mean, we started it, but it's spread across the world. You'll hear about it all over the place. People are taking it to extremes as well. You'll hear about day case joint replacement, which is popular in the States, but it's a bit of a different system in the States. They are discharged to medical hotels, so they're not discharged to home in generally. And that would be a reasonable next step here, because we don't have that here. So people either have to stay in hospital or they have to go to proper rehab, and proper rehab costs $1,500 a night. So why? What's the benefit? So until that happens, and they're building one opposite here, that building site just over next to Fiona Stanley, that's a medical hotel. So there will be potential for that. So yeah, it's continuing to evolve, but you know, it's unusual for people to have long lengths of stay nowadays.
So with a knee,
Yeah.
you have the operation, go home, say day 3.
Yeah.
What happens after that, or are you going to cover, like, if somebody wants to work,
Yeah.
how long after day 3
Yeah.
could they go back to work if
Yeah.
it is a desk job,
Yeah.
office job?
So minimum for a knee replacement, I'd say, is 4 weeks. If you were desperate to get back, you can't drive. For me, you can't drive for 4 weeks. Most people will tell you 6 weeks, most surgeons. You're probably off your crutches at 4 weeks after a knee replacement. You will still probably be on strong painkillers at night, but not during the day. And by 6 weeks, you can pretty much do everything. But like a desk job, if you're in a manual job, you're looking at a proper manual job like the FIFO workers and things, you're looking at 10 to 12 weeks.
You're just talking about sedentary.
Yeah, so if you're desperate to go back, it's 4 weeks. Yeah.
The limitation is what?
Driving initially, yeah, and then pain. Yeah, and just, one of the things you do not want to be doing after a joint replacement is sitting with your leg dangling down. You'll just fill up with fluid. So you've got to be in a position where you can stick your leg up in the air or walk around. So you can't be in a desk job where you're sitting all day, leg hanging down. That would be a disaster.
What's typical recovery from a hip replacement?
From a hip, yeah. So 2 days in hospital, 2 weeks on crutches, driving and back to most jobs 4 to 6 weeks. Sport at 6 weeks. It's like golf for 6 weeks.
So 6 months.
Yeah, but obviously not something right with that one.
What about robotics? Yeah.
Yeah.
Oh, I didn't. Yeah.
Some doctors recommend glucosamine with chondroitin. What are your thoughts?
Glucosamine? Yeah, so there's one early randomized trial saying it was as good as Brufen in terms of pain relief, but no trials subsequent to that have shown that effect. So my view on all those dietary supplements is I think you're welcome to try them, and if it helps you, and it seems to help some people in some bizarre way, then fine, I don't mind. But there's no science behind it. So that's, yeah, do it if it helps you. That placebo is important. So I've been asked about robotics down here. I'll come back to it later, but so robotics will become important in orthopedics. But robotics at the moment is reproducing a plan that the surgeon gives it. So it's not helping you to do a better job in terms of planning. So you've got to tell it where to cut. It's very accurate at reproducing that plan. So that's good. And if nothing goes wrong, then technically it's at least as good as the surgeon at reproducing that plan. So someone that's not doing many joint replacements, like the Americans. So how many knee replacements does the average American surgeon do in a year? 12. That's their practice. Most Americans are working in small town. Do you think of when you think of American orthopedics, you think of the Chicago and New York and Boston. They're the big surgeons that everyone refers to. Most people in America live in small towns, and their surgeon will do 12 joint replacements a year. So that doesn't make you an expert. So, the technology in orthopedics is very US orientated. So they develop technology to make surgery more reproducible for low volume surgeons. And that's where robotics is probably good. So robotics is good at reproducing plans. The problems I have with it is it was developed, the main company like Mako, Stryker, they developed it because they didn't want to develop a new knee replacement. So it's very expensive to develop a new knee replacement. So they got a good knee replacement that's old, and they wanted to prolong the life of it. So they promoted robotics as a way of making this knee replacement they already had better, whereas the other big companies, Zimmer and DePuy, had developed new knee replacements, spent billions of dollars on that instead.
It's not more accurate.
It's more accurate at reproducing a plan that you give it, but what plan do you give it? So the big question in knee replacements particularly, but also in hip replacements, is where do we put our implants? How do we know where to put them? And that's where other technology is being developed, which I'll talk about. So getting better at placing where our implants are, first of all, we've got to know where to put them. And that might sound really stupid, but we don't know where to put them.
One more quick question then. What sort of metal is it titanium or?
Knee replacement, there's a whole bunch of them at the back, I think. So 95, knee replacements talking about?
Yeah.
So 95% plus of knee replacements are cobalt chrome femurs. So cobalt chrome, really shiny silver metal.
Titanium?
No, not titanium. Never, ever, ever titanium. So titanium is a rough metal. You don't want rough. You want hard, shiny material. So cobalt chrome.
China, does it by any chance?
No, most orthopedic implants. It's one place that China does do very badly in manufacture. Most orthopedic implants are made in Europe, particularly Switzerland and the US. So, and UK. So cobalt chrome, really hard bearing. So you want a really hard, shiny bearing. So cobalt chrome, we used to make most hips out of cobalt chrome, the ball part. We still do lots of people, but we use lots of ceramic heads as well because they work really, really well. They've been around for a long time and they're inert. And then the stems, so hip replacement stems are made of titanium if they're uncemented, because bone really likes growing onto titanium. The cups are made of titanium because, again, same reason, bone likes growing onto it. The bearing on the cup side is high density polyethylene, although you can use ceramic, but that has its own issues. And then there's very few hip replacements that are metal on metal, and that's usually resurfacing. On the knee, you've got polyethylene bearing, same material again, and then you've got the base plate. This is where the titanium comes in. So on a knee replacement, sometimes the base plate, the bit on the tibia, that can be made of titanium because that's not a bearing. It's holding the plastic. So titanium is not a good bearing. And stainless steel is kind of dodgy.
You mentioned people sue because their legs are different
Yeah.
lengths. If one leg is short to start with, can the knee replacement make them the same length?
Only a few millimetres. So all a knee replacement does is put you back to where you were. So if you've got bent knees like this, mechanically you've lost a few millimetres in height because you've got a bent knee rather than a straight one. So when you're straightened out again, you'll go exactly back to where you were started. But you can't really change a leg length with a knee replacement. With a hip, you can lengthen it, shorten it, do anything by a lot. So it's the hips that's really a problem. Expectations, quickly go through this. This is what patients want. This is what you guys want. You want surgery tomorrow. You want better function than a 25-year-old. You want no complications. You want a normal knee. You never want it revised. And it's got to be cheap and convenient. It's true though, isn't it? That's what you want. That's what we want. That's what we want you to have. But if you come in expecting that, you're going to have a very sad face. Slightly sad face. So the truth, there will always be complications. So you need to go in there with your eyes open. There's 1% infection, there's 1% DVT, there's 1 in 1,000 PEs. Some of them will fail. 10% will fail at 10 years, 20% will fail at 20 years. You might be one of those. So what do you want when you go and see a specialist? You want a good experience. You want to trust the team that's looking after you. So you want them to be using things that make sense, not things that are the latest of the news. You want good pain management because that makes your satisfaction better. You want early recovery, that makes satisfaction better. You want to get back to the things you want to do. You want realistic expectations that are going to be met. And you want to use the best stuff, not stuff that promises you stuff that can't be delivered. Knee replacement, it is a very good operation. What are the 4 best operations in the world for quality of life?
Hip replacement.
Hip replacement is number 2. Number 3. Coronary artery bypass, number 3. Knees number 8 or 9. And shoulders definitely not. Sorry. Cataract, number 1. And number 4 is renal transplant, kidney transplant. But knees and hips are good, particularly hips. Knees are good though, knees are great. Survival, we already talked about, 80 to 85% survival, Australian registry knee replacement. We've got the data on that. UK is the same. If you're younger, you do worse. So the older you are, the better outcome you get after a knee replacement, because you've got more realistic expectations, but also people that are younger, they've worn out their knee for some reason. It might be trauma or it might be something weird, so they're harder to treat. Whereas if you're 65, you've got common or garden arthritis, they do very well.
So just on that, is there a maximum age?
No. No, often asked that question, yeah.
if somebody's been living with a bad knee for a while,
Yeah.
can they get to the stage where the knee is just too bad that you can't do anything?
No. But their expectations need to be tempered, especially stiffness. So that's a common factor. So the stiffer you are before a knee replacement, on average, the stiffer you'll be after a knee replacement.
That's still better than before.
Yeah, that's right. What's this one? So yeah, better outcomes the older you get. Look at this. So this is revision rates. If you're less than 60, you've got a 35% chance of having another operation on your joint replacement. If you're more than 70, you've got only 5% chance of having another operation in your lifetime. How long do you live after a joint replacement? You live longer than someone that hasn't got a joint replacement. On average. So younger people more likely to require revision. So we think about different operations. We've kind of covered this. We talked about when to have a joint replacement. But at the end of the day, this is what you're heading towards, particularly if you're young. If you're young, the joint replacement's likely to work really well, and you're going to have great time with it, but then it's going to wear out and you're going to have it done again. So you're kind of investing, you're having your quality of life now, and later on you're going to have a revision which might have problems. So that is the choice you're making if you're young. Can we improve survival? There's some bad truths here. Use a good implant. Sounds obvious. Don't use something dodgy. Don't use it because the rep's been round and promised you a trip to Italy. That happens a lot. Surgical volume. We talked a little bit about this. So the more you do, the better you are. There's no getting around it. Technology. We talked a little bit about this. PSI, robots, navigation. They're all interlinked. So as I said, it's very expensive to develop a new hip replacement. It's very expensive to develop a new knee replacement. So companies don't want to do it. Regulation's terrible now, and they're good. Why develop a new one when they're good? So what companies are focusing on is putting the ones we've got now in better. So they're doing that by planning, by using robots. We'll come back to that a little bit. This is computing power in the world, all right? So now where are we? 2020. So by 2060, is that 60? I can't read it from here. Yeah. So we're more than, is that insect brain? Yeah. So insect brain, we've passed that. Mouse brain, we've passed that. Human brain, we're at that level now. So we've got computing power equal to a human brain. And then by 2060, we'll have computing power equal to the whole of humanity. That's scary. So what does that mean? Is that we feed in loads of information, loads of point outcomes into our computers. They will start figuring out what's the best thing to do with our joint replacements. They will start telling us, if we give them the information, they will tell us where to put the hip. That's what we were missing with the robots. Robots don't know where to put them. We don't really know where to put them. But if we give them computers enough information, they'll figure it out eventually. And that is now, that's what's happening now. So we're in the process of collecting that data. So if we come to our practice, our knee replacements get pre-operative collection of data, they get post-operative collection of data for a year. That data goes into a massive database, and that is every day that's getting stronger and stronger and predicting who's going to do well and where to put that knee replacement. This is the kind of score that we're ending up with. So sad face, happy face. This is pre-operatively. So from factors that we can take from you guys, before you have an operation, I can predict whether you're going to do well or whether you're going to do badly. That's interesting. So that would come. So, and then we're on to controversies. I'll just whiz through this and then we'll have final questions. So supplements, we covered a lot of this. Supplements, these are things I'm commonly asked. Supplements, we talked about this. They are largely placebo. If they work for you, keep taking them. The only one to stop is fish oil when you're coming up to an operation because it makes you bleed. So stop that a week before. Financial harm, I call that. PRP. PRP is Plasma-rich protein, so they spin platelets down, they take out all the good stuff from inside the plates and they shove it into things. It is got some promise with inflammatory conditions in tendons, so particularly in the shoulder and the elbow, some around the knee and the Achilles. With arthritis, it has no place, and anyone that does it is ripping off patients. No better than placebo. Stem cells, even worse. People will charge you $9,000 for putting stem cells into joints. There's no evidence that works. It makes no sense at all. It might work in some tendons. Makes no sense. And people, you know, it's not funded by Medicare. It's not funded by health funds. Why is that? Because it doesn't work. Don't do it. Navigation. Navigation, robots aren't just navigating. We've had navigation for a long time. Robots just reproducing navigation. That's not really the question. Navigation does improve accuracy in knee replacements. We proved that 20 years ago in Perth. But it doesn't tell you where to put it, as we said before. Functional navigation does. So this is the new area. So we are taking some fancy CTs preoperatively. From that, we can predict where your hip replacement should be placed, and then we can reproduce that positioning during the operation. This is the big breakthrough in orthopedics, not robots. Why do we want to improve positioning? Because we don't want hip X-rays that look like that, with both hips dislocated. We can improve stability, dislocation rates. We can reduce fractures. We can improve muscle function, leg length. And in theory, long term, we can improve the longevity of the implant by putting them in the right place. It's all good. These are the kind of little guides that we have during the operation to reproduce those plans that we've made preoperatively. This is what we should be doing. This is really good. For instance, this is showing a very stable preoperative hip. So you can put a normal hip replacement in this one. This is showing an unstable hip. So this is the movement pattern across the cup preoperatively. So this patient is able to move right across their cup. This is a high risk of dislocation. They get a different implant. Then we've prevented them dislocating post-op. Brilliant. Robots, they are going to be the future once we figured out the plans. How much does the robot cost? $1.2 million. Who pays for that? You do. How long does it take for me to do a knee replacement? Half an hour. Half an hour. How long does it take a Mako? 3 hours. Think about the resources there. Each Mako costs $5,000 on top of the implant with disposable equipment for each operation. $5,000, $1.2 million, 3 hours operating. We should not be using these. Approaches, anterior, lateral, posterior. That's a rather long posterior. Commonly asked about anterior. It's a more difficult operation to do. Your scars at the front, you're more likely to get a nerve injury, and your femoral component's more likely to be in the wrong place or fracture the femur. Good side of it, it's probably the most stable approach. If you get a good surgeon doing it, they'll do a good job. Posterior approach, same muscle damage as an anterior. Recovery is the same, discharge is the same, you can't see the scar. If something goes wrong, you can extend it up to the pelvis and down to the knee. This is the utilitarian approach. If I want to do anything through here, I can do anything. As you might have guessed, I do posterior. Lateral, if there's anything that's come out of the argument between anterior and posterior, it's that lateral is bad. Lateral cuts through the muscles that you walk with. That cannot be a good thing. That's out the window. Don't have it. Anterior with a good surgeon that has done more than 100. Posterior with everyone else. Posterior approach. Here's my posterior approach. Not on everyone. You see how skinny this girl is. But it's what happens inside. You know, skin incision is about weight. Nice scar. It heals well. No special equipment. It's not a more unstable. Here's an anterior scar. It's at the front. You see it every day. I think it's ugly. Some people like it. There's a nerve that runs down here that gets injured in about a third of people. It's a sensory nerve, so you get a numb patch. Outcome, if you look at all the hips done in Australia over the last few years, as opposed to approach, lower revision, so you're less likely to have it revised if you've got a posterior. More infections of posterior, interestingly, and more dislocations in everyone. This is small numbers. Anterior, higher revision, so you're more likely to have another operation, and that occurs within the first month. And that's largely due to dislocation and fracture, ironically. So, pros and cons. I'm not saying don't have an anterior approach. I would say the most important thing is be very careful who does it. Have someone that has done a lot of them, because it's not an easy operation. Hip resurfacing, a particular like of mine, for young active people, you're keeping all the bone, they can do anything on it. It is a metal on metal bearing, it's a harder operation. The outcomes are much better than any other hip replacement that we have. Again, there's pros and cons of it, and it's only suitable for young men. So this is my selection criteria. Don't do it on young women, don't do it on deer or antelope, don't do it on dwarves or rodents. The results are ridiculously good. So if you pick the right patient, no revisions at 15 years. That's ridiculous. This is in people under 50, men. But you have to be young, you have to have good bone stock, you have to have arthritis. You've got to select your patients correctly and use the right implants. I'll just whiz through all that. Just to let you know, ceramic hip resurfacing, new thing, there's only 4 surgeons allowed to do it. I'm one of them. It's experimental at the moment. We've done 150, we've had 1 failure, so that's really good. It's an experiment, you have to be in a trial. And you have to be young and have good bone stock. So in summary, results of joint replacement, fantastic for resurfacing, may not be applicable to all of you. That's it.
In general, in the 4 weeks post the knee, what's a typical sort of program for or rehab to maximise the benefit?
Yep, so your first 2 weeks, just reproducing the exercises that you've done, that you were taught in the hospital, just getting your movement and strength back, mobility back, get your swelling down. So swelling management, really important in the first 4 to 6 weeks. So ice packs, we have these icemen that go over and give you cold water. Get the swelling down, manage your pain, you're not doing too much.
So can you do that yourself?
That's at home, yeah. Week 3, wounds are healed, go in the pool, start getting your movement back, start getting more bend back. So what you'll find is day 0, day of operation, you can bend your knee to 90, 100 degrees and lift your legs straight and you don't have any pain. You lose all that in the first week. And then you're fighting, and that's because of swelling and the pain coming back. And then the next 3 weeks you're aiming to get all that swelling away and get back to that state. So then you get rid of your crutches about 4 weeks for a knee, about 2 weeks for a hip, and then it's just a slow recovery. You will continue to improve after a knee replacement for 6 to 9 months.
But do you have to attend a physio or
I would recommend that you see a physio after a knee replacement. Most people after hip replacement don't need one. If you go through our program, then you are automatically linked to a physio as part of your whole process, and you see them preoperatively, and then you have remote access to them with an iPad for your whole recovery until 6, maybe 3 months, I think. And they follow you up over the internet. But that doesn't replace having a physio for a knee replacement.
So it's part of your program, not only the operation but the actual recovery and so forth. Is that typical of other colleagues?
No.
Do other colleagues, once you leave the hospital, that's it, you're on your own sort of?
Yeah. I mean, different people have different things. Some employ their own physios. Some people send more people to rehab, although that's reducing because the health funds won't fund it. Some people will book you in at 4 weeks or something like that. It's an individual thing. I don't know what other practices do.
A preparation before a knee replacement surgery.
Yeah.
What sort of exercises, or should you do extra exercises?
Yeah, it's good. So any weight loss is good. Non-impact exercise, so in the pool, anything in the pool is good, swimming or walking, and a bike, like a gym bike, exercise bike, and that's good pre and post-op. They're all good, but those are if you were limited, those are the best things to do. So weight loss, exercise bike, hydrotherapy. Hello. The back?
Yeah, airport metal detector.
Yeah.
Do they believe that you've had a knee replacement?
They never believe you've got a knee replacement. So they always stop you, and it doesn't matter what you have on you, or you just show them the scar and they'll wave their magic wands at you. And they'll make you feel bad. So just need a little bit more time to get through security. There's nothing else you can do about it. Hello.
Could I ask, would low bone density cause any issues
For
for things like that?
hip or knee?
Well, in my case, hip.
Hip.
So I'm told that that's
No.
the most debilitating.
Yeah, so all it does is it changes our selection of implants. So for me, if someone is proven osteoporotic or elderly and you're expecting them to have poor bone, then use a cemented hip replacement. That's the only difference. There's no problem with that. Hello.
I've been told with a knee replacement, if the scar isn't a medial, then the chance of kneeling, flat bearing is higher.
What it is with the scar is that your nerve supply to this part of your skin is from here. So the transverse branch of the saphenous nerve comes across here. So all scars go down here. So you will always clobber that nerve. So you will have an area of numbness over here, which will vary. And you can vary that in different ways. So if you put your scar more laterally, this area here will still be innervated by that nerve. That's what you're talking about. So if you have a medial scar, you will get more nerve loss in that area. If you have a lateral scar, you'll have less nerve loss in this area.
So do you do a lateral scar?
It depends on the patient. So usually I'll do a medial scar. If they are valgus, so if they're like this, and I'll go down the other side and do a lateral scar. I don't change it for the nerve issue. And the reason for that is that even once you're in there, you're still going to undermine to get to where you want to be, and you're still going to affect the kneeling. I don't think it entirely relates to the sensory thing is a different.
It's a scar that stops you from being able to kneel, so that's not.
There is some evidence of that, and people are modifying their scars to try and compensate for that. So they're putting them over here. So there's the nerve issue, and then there's the scar issue. So your scar, if you're kneeling on your scar, that in theory you might think that that's going to be better. I don't think we've got good evidence for that. But I think at the end of the day, the people that can't kneel are the ones that can't kneel preoperatively because of pain. And there's two reasons why you can't kneel. So someone comes in and say, can you kneel? And they say no, and it's nothing to do with pain or numbness, it's because they can't get up. So about half of them, they can't kneel because they can't get up. So that's to do with muscle strength or weight. And the other half, it's because it feels funny. So everyone can kneel, it never hurts the implant. So it's to do with your comfort and it's to do with you getting up. And maybe you can modify the scar a bit. I don't think we've got good evidence on that. It'd be a good thing to be able to fiddle around with. Hello.
Is it appropriate to get a second opinion?
Absolutely.
And nobody's feelings get hurt?
Yeah, they do. But what's it? Patients get very understanding. I reckon the best research in orthopedics would be about the psychology about orthopedics, and no one's really looked into that. And one of the things that you see all the time is that a patient will go to a doctor and they will establish a relationship with that doctor. Okay, so these are patients with a problem usually. They establish a relationship with that doctor, and if they're happy with that relationship, and most people are happy with the first person they see, then they are extremely reluctant to go to someone else. Whatever happens, the most horrendous things could happen, and they still won't go to someone else because of exactly what you're saying. They feel some kind of attachment to them. And then you've got the other end of the spectrum where there's people that will go and see 6 different doctors till they get the answer that they want. And that's the problem group. But yeah, in fact, when I see a patient with a difficult problem or with a complication that I've had, I will tell them to go and have a second opinion. And one good thing about our practice is that we're nearly always running clinics parallel. So I run most of my clinics with Leon Lamb next door or Gareth Prosser next door. So we've got 3 rooms in our practice. And if I've got a problem or a difficult case or some complication I'm unsure of, then I'll get them to come in and see the patient straight away. I don't think anyone else does that. and they don't get charged for it, and they've immediately got a senior orthopaedic surgeon telling them that I'm doing the right thing or not. It's great, although conflicted. Yeah.
How do I get an appointment?
I'm booked out. When am I booked out till? 5 weeks for a clinic appointment and 3 months for an operation. It's so busy at the moment. Everyone's busy, and theatre and hospital access is really difficult. The hospitals are all full.
So just on that, how do you assess who to go to?
Yeah, so this is what I'm talking about, this is another psychological thing. So how do GPs decide who to refer to? How do patients decide who to go to and who have an operation with?
Who they went to uni with.
Well, yeah, definitely, in WA particularly, but it's most of them have got referral patterns, so they don't really think about it. They've got an easy pathway. I refer all my hips to him, and I refer all my knees to him, and I refer all my sports to him, and they don't think about it, just do it. And most of the time that's fine. So that's how I think GPs work. The other way that GPs, the way that we can affect that, by far for me, is good patient experience. So if a patient has a good experience, they will tell their friends to go to that surgeon. And that's, as I've got more senior, I had a big public practice before I started private, so I already had quite a big GP base. But what I've seen, particularly in the last 10 years, is that 2/3 of my patients come from previous patients. And because we do trauma as well, so our patients have a fractured wrist or a fractured hip, we get them without, that's a really easy referral for us, because they're coming in through an ED department, they're referred to us because we're on call, and then they get a good experience, and then suddenly we've got a new referrer. So things like that. But yeah, it's really interesting why people, and what, there are bad clinicians, there are bad surgeons that have bad results, and GPs will continually refer to them, knowing that they have bad results.
Do you ever find that out as a patient though?
Yeah, exactly. How do you? It's really hard to choose your surgeon as a patient. And what it comes down to is what we're talking about, is that initial relationship you have with the surgeon when you meet them on the first consult. That's when you decide when you're going to have an operation with them. It's not, at the end of the day, it's not whether they do anterior or posterior approach, because loads of patients come to us and say, oh, can I have an anterior approach hip replacement? And I'll say no, but they'll still have an operation with us because they've established that relationship and they can see that we're sensible.
I wanted to ask you what the cost is of a hip replacement for somebody not on Medicare, not on HBF.
Yeah.
A temporary resident waiting.
Not on Medicare.
No, we're temporary residents waiting on.
With no insurance at all.
I've got HBF, but they said not for hip replacement. It's an
So a person with Medicare has privately funding is about $25,000 to $30,000 for a primary hip or knee. That's with Medicare. Without Medicare, have you got any idea?
It's the same amount, it's just for a Medicare holder, they would get some rebate, probably about 4,000 to 5,000 rebated, part yours, part the anaesthetist, the assistant, and some of the specialist tests, but the hospital component would not be reimbursed by Medicare if you don't have a private.
Yeah, so about $4,000 or $5,000 difference, and then on top of that, then the specialist would normally charge more, wouldn't they?
AMA rates.
Yeah, so they'll charge more than HBF rates, just because they're taking more responsibility. So yeah, so you're looking about 30 grand if you've got no cover at all.
So if you've got full cover,
Yeah.
like Medicare and private,
Yeah.
that's rough.
So at the moment, all our surgeons are no gaps, so no gaps for us at all, 0. So you'll have gaps in relation to your cover within the hospital, so whatever excess and things like what you've negotiated. So so St John's is really good for HBF, They've got deals with HBF, but they're really bad. Everyone's bad with Medibank Private because they don't deal with anyone. And then all the other health funds are kind of variable. Some are good and some are bad. The ones that are cheaper tend to have very high gaps with the hospital, but at the moment we don't charge gaps at anyone at all.
Thank you.
Dr. Respect, doing both knees at the same time.
Yeah.
I know you ran over it. A friend of mine, you helped him out.
Yeah.
And he had both done at the same time.
Yeah.
And he's recommended me to do that.
Yeah. I'll still do it, but I just think people do better if they don't. If there's a compelling reason, the usual compelling reason is that they're working people and they can't afford to have the time off, so they want one episode. Yeah, but yeah, I'll still do it, but I'll always tell you what I think's the best.
And you think you get a better outcome by doing them separately?
Yeah, I do.
Any additional complications from chemotherapy or lymphomas?
Actually on chemotherapy?
No, if you've had them or have them,
It-
and you have knee replacements, are there any extra considerations or complications?
So it depends what chemo you've been on. So it basically comes down to the side effects of the chemo, and these days there's not much. Probably on the heart and the kidneys are the worst things. So they'll give you certain medical issues, but from the knee itself, if you're actually off the chemo, then no.
So what about heart problems?
Yep.
I've got a stent.
Everyone's got a stent, haven't they?
So there's no problem?
Everyone gets assessed for what problems they have. Stents are very common. They're usually, the only difference is that we'll keep you on aspirin during the operation. Or clopidogrel, or whatever you're on.
And you mentioned before about possible infection
Yeah.
in the joint.
Yeah.
What road do I go down to try and find out what it is?
You have to see someone for that. It's very specialist. Yeah. It's not an easy thing to deal with. Hello.
What about the gastric problems with the medication,
Which ones?
painkillers?
Which gastric? The anti-inflammatory, like stomach burn things? I think if you cannot have anti-inflammatories, you're significantly inhibited with a knee replacement. I think anti-inflammatories make a big difference.
Right, what about the hip?
Hip, the anti-inflammatories don't make so much of a difference, so it's not as big a problem. With the knees, I think anti-inflammatories are really important. And there's plenty of people that can't have them, but I really notice the difference. It just means they're going to take longer and they'll be stiffer and they'll be more swollen. They'll still get there, but they'll just find it harder.
Oh.
Yeah.
So, if you go down the road of having physiotherapy instead of a knee
Yep.
replacement, how long can you sensibly expect to last?
It's really individual. So for most people that doesn't work. So if you're skinny and you're fit, then it's probably not going to make much difference. If you're overweight and you've got other medical comorbidities like diabetes and things like that, it could make a huge difference. And it could make you much better off to have the operation 2 years later. But if you've already kind of done all that stuff, then prehab's not going to work. But it's an individual thing. If it's something you're keen on and you're not completely crippled by your joint, then do it. And there's certain there's a few practices around town that are specialised in prehab now. The first group that did it is HFRC in Sterling Highway in Netherlands. They are the premier prehab group in WA. They did all the research 25 years ago. But there's other places that are promoting prehab. And prehab, good. Prehab does work. The time we actually notice it is if they have it immediately before an operation. So prehab over a long period of time just to prevent an operation, that's one thing. But prehab before a booked operation, you can tell.
Mine was the first one.
Yeah.
So,
Yeah.
So just keep going for as long as you feel you can.
Yeah.
So it starts to give you a lot of relief.
Yeah, until, as I said, until it inhibits you doing things that you sensibly should be able to do. So, you know, if you came to me and said, my hip really hurts, I can no longer play squash, I'd say stop playing squash. But if it's because you can't sleep or you can't work or you can't walk and you're on opiates, then you need a joint replacement. Low.
Do low platelets affect your surgery on hips and knees?
Yeah. Make you bleed.
Yes.
So below 50, 50 is the number that we look for. But then again, a lot of platelet diseases, they're not only low, but they're also abnormal. So ITP being the common one. So you can have normal platelet levels that don't work, and that will make you bleed just as much as having low platelets, really low platelets. But below 50, then what happens below 50, the problem is that it stops you doing a spinal anesthetic, stops you doing anything in the spine, because you might bleed into your spinal canal, which is bad. So I did one recently, actually, and we just need to have platelets available, and you need to be worked up by a haematologist. But it's still doable, it's just more complicated.